Hi, and welcome to my presentation on Kawasaki disease surveillance, what we know and need to learn. My name is Maren Jensen, and I first became interested in Kawasaki disease about a year ago when someone I know contracted this disease and was in the hospital for several weeks. What is Kawasaki disease? It's an acute self-limiting febrile vasculitis of unknown origin affecting children, and it was first described by a Japanese doctor, and since then has been known to occur worldwide since the 70s or late 60s. Kawasaki disease involves inflammation of arteries throughout the body, including the coronary arteries. Aneurysms and heart damage can occur, especially if not treated early enough. And it is the leading cause of acquired heart disease in the US for children. It can also be referred to as Kawasaki syndrome or mucocutaneous lymph node syndrome. There are three phases of symptoms. The first is the acute phase and can be quite severe and intense. There's a fever, potentially quite high, of 5 days or more, and it doesn't respond to over-the-counter painkillers. As well, there can be conjunctivitis, sore throat, swollen and chapped lips, a red and swollen tongue, which is referred to as strawberry tongue, rashes around the body, and swollen lymph nodes in the neck, especially. Next is the subacute phase, beginning maybe 12 days to 21. Symptoms from the first phase are less severe. The fever reduces. Other symptoms include peeling of the skin on the toes and fingers, stomach issues, joint pain and swelling, jaundice, lack of appetite, and it can be painful, and the child can be quite irritable. And as well, complications can begin to occur on the heart or other organs. Lastly, the convalescent phase is as the child gradually recovers from symptoms and all outward signs of the disease are gone. It is diagnosed clinically with no one test being used to confirm at this point. Lab tests are used to rule out other diseases, such as infections or arthritis. There are several. These tests include measuring platelets, ESR, C-reactive protein, antibodies, rheumatoid factor, albumin and liver enzymes. There's cultures, urinalysis, and a chest x-ray, as well as electrocardiogram and echocardiograms, which really need to be begun as soon as Kawasaki disease is suspected, so that a baseline echo can be available in comparison to later echoes. Most children are hospitalized for monitoring even prior to confirming this diagnosis, since it may take a while for these tests to be done. Complications that can begin to occur during the second phase are referred to as coronary artery abnormalities, such as aneurysms and dilatations, as well other heart issues, including heart attacks and congestive heart failure. And greater than 20% of untreated Kawasaki disease patients have been known to develop these CAAs. Complications can also affect other organs, since aneurysms can occur elsewhere, and also the symptoms for long term can have effects as well. Also, other infections can be concurrent or just prior to Kawasaki disease, potentially affecting its onset. And this was the case with the 4-year-old boy that I knew of about a year ago. These infections can worsen symptoms or confuse and delay diagnosis and treatment. The treatment that is being used is intravenous immunoglobulin, or IVIG, which is a boost of antibodies to help fight infection. And symptoms tend to improve quickly, such as within 24 hours. However, some cases do require subsequent doses. Also, high-dose aspirin is used to prevent blood clots and reduce fever, rash, and joint inflammation. And typically, children are not given aspirin, but Kawasaki disease is one of those exceptions. Other drugs may be administered to help arthritis pain or antiplatelet coagulants, or others that can be used to treat symptoms. If diagnosis is unclear, potentially even those to treat infections. Follow-up should be 6 to 8 weeks after symptoms start to monitor the cardiac arteries and heart if there has been any indication of CAAs. And aspirin therapy will continue until symptoms subside. It has been over a year since the patient I know of had Kawasaki disease first starting, but is still on aspirin therapy as his arteries, have not returned to normal size. There are important reasons for surveillance. First of all, we are unsure of the etiology of KD, and therefore we need more information on determining risk factors and exposures. There's hypotheses existing about microbial agents, chemical exposures, toxins, autoimmunity, and genetic susceptibility in relation to KD, as well as we need to better understand the outcomes from their episodes with their accompanying risk factors. What's the responsiveness to IVIG or other possible treatments as well? So the surveillance questions that I came up with in approaching this topic were how much surveillance has been done and what information was being collected during those surveillance studies. What is the incidence in Japan, the United States, and other countries? And what risk factors then are known from this surveillance? Are there possible etiological risk factors that are seeming to be apparent? And what are the risk factors for heart complications in individual patients? Also, I was curious about the treatment response trends and if relapse episodes or chronic symptoms are very common or not. To have good surveillance, we need a good case definition, and the CDC, as well as other reports, listed the following. A complete diagnosis is referred to if there's a fever of 5 or greater days, plus 4 of the following symptoms: rash, cervical lymphadenopathy, bilateral conjunctival injection, oral mucosal changes, and the peripheral extremity changes. If this isn't met fully, then if there is at least the fever and the CAAs developing, then it is considered an atypical or incomplete Kawasaki disease case. So what surveillance has been performed? In the United States, passive surveillance has occurred since 1976, administered through the CDC and collecting case report forms from doctors, hospitals, state agencies, and that is at their own determination, being passive surveillance. Also, many retrospective and active studies have taken place in Japan, Europe, individual states, and other countries. Currently, there are active surveillance studies being performed in the UK and Ireland, Taiwan, and Canada. And typically, the case report forms include patient data and the clinical outcomes, diagnostic criteria used, the cardiac studies being performed, such as echoes, and the complications involved. And through the surveillance, the known risk factors at this point are males have a higher risk, 1.5 to 1, female, about 60% of cases. Children less than 5 years old make up about 80% of the cases, and Asian and Pacific Islander heritage patients have a higher risk. As well, the hypothesized potential etiological risk factors involved include a genetic factor, which is what is being hypothesized at this point, although it is still not confirmed. And because there's a seasonal variation in reported epidemics in some studies, there's a high suggestion that some kind of environmental factor is involved, such as a viral infection that can trigger the condition. What are the risk factors for developing CAAs? Again, we see that males have a higher risk ratio, as shown in parentheses. The age group less than a year or the age group older, 9 to 18 years, have a higher risk ratio in comparison to the 1 to 8-year-old group. Asian Pacific Islanders have a higher risk ratio for developing CAA, as well as Hispanics. And these values were taken from the CDC's most recent report, which was covering the years 1994 to 2003. In reviewing the studies, I decided to make a chart to be able to visualize them all together. As stated before, the percent of cases that are less than 5 years old patients are typically about 80%. The male percentage is around 60%, or a 1.5 ratio in compared to females. A few studies reported their incomplete or atypical diagnoses percentages. Majority of patients are receiving the IVIG, and you can see about 10 to 20% of CAA development in Kawasaki disease patients. As well, you can also see in Japan, we have the highest incidence there at the top, by far the highest incidence, as well as Hong Kong and Hawaii having an elevated incidence compared to the rest of the US or the Netherlands and European countries. There were some unanswered and follow-up questions that I developed through this review of surveillance. The treatment response trends and relapse episodes or chronic symptoms were only mentioned slightly in reports. I was curious to know what kind of treatment or diagnosis improvements might exist since the 1970s, since data has been collected. And I also felt it's important to have the recent patient exposure history on the CRFs, which is included on Canada's current active surveillance project right now. The limitations that I came across were, one, the passive surveillance, being just only able to collect a small percentage of diagnosed patients. And of note is that recent studies that were actively pursued had a very high, greater than 90% survey return, which is awesome. And potential limitations are perhaps more severe cases are being selectively reported by physicians, and incomplete atypical cases might not be included in analyses, which I think is probably may begin to be incorporated in analyses moving forward. Incomplete CRFs are always an issue, and we should probably be including important information regarding patient exposure history and genetics, and long-term follow-up, and those are all limited thus far. In conclusion, as a leading cause of childhood acquired heart disease, a lot of unknowns still exist regarding Kawasaki disease. Continued and more specific surveillance is necessary, and researchers have recognized this need, and several such studies are underway. More active surveillance is a much more effective method of acquiring data, and therefore recommended when possible. With these efforts, I feel the important questions regarding etiologic and outcome risk factors will be able to be answered. I had several references that I reviewed and pulled data from. I have them listed here. I'm grateful that I was able to learn more about Kawasaki disease, and I'm excited to see what else is learned in the future years. And thank you for your attention. I look forward to your comments and questions.